am Dr. Dave Kean. I'm still employed as an assistant professor in the athletic training program. And I'm honored to introduce one of our second-year students, Jay Smith, and he's going to give a very interesting talk about prevention and rehabilitation of stress fractures. All yours, Jay.
Thank you. I don't know how to follow that up. What a performance. Hello, my name is Jay Smith. I'm here to talk about, like you said, preventative care and rehabilitation techniques for stress fractures, particularly in collegiate athletes. So stress fractures are microfractures that occur within cortical bone. That is the kind of the spongy stuff towards the middle of your bone. And each sport has its own risks for where stress fractures may occur. Most common are the tibia and the metatarsals. Those are where you're going to see most of your stress fractures occur within athletes. So some of the epidemiology and risk factors, the most significant one found was being a female athlete. The female athlete triad, which is low energy availability, without disordered eating, or with it, menstrual dysfunction, and low bone mineral density have been found to be the biggest causes of bone stress injuries. It's been found that overuse or sudden changes in activity levels are most likely to cause a bone stress injury, and those who are insufficient in vitamin D have a higher chance of suffering a bone stress injury. So in collegiate athletes in particular, lifetime prevalence is 10%. It doubles for collegiate athletes all the way up to 21%. Almost 60%, so a large percent of stress fractures occur either in metatarsals or the tibia. And then there's been an increase in the overall incidence rate of bone stress injuries in the past 2 decades. So in 2003, about only 1% of athletes were exposed to a bone stress injury, and the latest studies show 20% of athletes. So a fifth of athletes being introduced to these injuries. My clinical scenario, so my PICO question is focusing on collegiate athletes with stress fractures, looking at the preventative strategies and rehabilitation programs compared to not doing anything, and then the changes in the return to play timeline that are caused by this. So my research methods, I used PubMed, Sports Discus, and Google Scholar. It pulled 517 articles using my keyword searches of stress fracture, bone stress injury prevention, rehabilitation, return to play, and epidemiology. And out of those 517, 6 were used for this topic. Inclusion criteria written in English, peer-reviewed articles, and studies focusing on the return to play parameters. My exclusion, studies before 2003, studies about medial tibial stress syndrome, and articles about pre-adolescent or professional athletes were excluded from this. Here's my research analysis. I graded all 6 of my articles on the Pedro, Strobe, or Amstar 2, depending on what type of article they were. So my first article looked at 74 athletes over 10 years at a Division I college. The first article published about bone stress injuries was this article in Collegiate Athletes. And it set the standard for the basic return to play protocols that are used to this day. So the first phase, you reduce activity level. The second phase includes pain-free, low-impact, weight-bearing activities. The third phase, you move into sport-specific high-impact movements. And in the fourth phase, you are finally pain-free and you begin your return to play process. This article looked at 2 Division I NCAA cross-country teams. There were 135 total runners studied. It found that it is important to understand what your athlete is consuming and using the right dietary program and supplements in order to decrease the risk of injury in your athletes. And it's important to encourage them to continue to take the right amount of caloric intake because even with the supplements, that's not enough. They need to be at their level in order to maintain a healthy lifestyle for the extra calories they're burning, because if they fall below that caloric intake, it actually increases the risk of a bone stress injury. This was a review of all known literature. It used 186 articles as supporting evidence and used those to draw conclusions about collegiate athletes. So it found that each individual has a unique training threshold at which this injury will occur. So a lot of these injuries are caused by overtraining or not taking any breaks during their season, but each person has a specific level that is different compared to all other individuals. More activity performed by running athletes led to more injuries with bone stress injuries. It's been shown that starting a sport at a later age, so not doing it during your youth years or taking breaks in your year-round schedule. So a lot of high school athletes or even collegiate athletes these days, with the collegiate athletes, they really don't have much of a break. They're always training. There is no off season based off, even though what you think when they're off in the off season, they're still doing 20-hour weeks and practicing constantly. So having those breaks in the schedule can greatly reduce injury. And there was anecdotal evidence that electrical stimulation could even be used to help shorten the return to play process in these athletes. This one, once again, looked at female track and cross country athletes, found that 34 athletes sustained an injury out of the 211, and it used an MRI to grade the injury. It was found that athletes with a higher grade MRI distribution had prolonged return to play, and that the average grade was 2, and athletes with a grade 3 injury based off the MRI had extended return to play timelines. This one used the NCAA injury surveillance program, so it went through and looked at all the stress fractures specifically, not just bone stress injuries. And it reported 671 out of those 11, almost 12 million athlete exposures. Found that a fifth of them were season ending, almost half of them returned between 7 to 21 days, and then 20% of athletes returned within a week. It also found that a fifth of all stress fractures that occur are recurrent, so once you have it once, you're more likely to have it again. And it found that the sports that were most affected were women's field hockey, women's gymnastics, men's football, and women's outdoor track. And then the last article looked at the 323 female athletes that came in for pre-participation physical exams and bone scans. And it compared injury rates with risk factors. The highest risk factors it found was low body mass index, low energy availability, delayed menarche, oligomenorrhea, amenorrhea, and low bone mineral density. And this goes back into talking about that female athletes, the female athlete triad is the highest risk factor to cause these bone stress injuries. So female athletes are at a much higher risk than male athletes, their counterparts, especially in the collegiate setting. Limitations. So currently there is little evidence specifically about collegiate athletes, which was surprising to me because this is one of the most common injuries that occurs in college athletics right now. It said 1 out of 5 athletes is going to experience some type of bone stress injury, which can progress into a stress fracture if not prevented and treated correctly once those signs show. Current prevention strategies are also limited. There hasn't been a lot of studies done into what we can do to prevent these injuries outside of making sure that the athletes are taking the right amount of caloric intake, they are taking breaks in their training. So trying to find what other prevention strategies is a good look into the future. Implications, when these methods are applied throughout off-season, preseason, and the competition season, as far as the preventative techniques, the training cycles, the supplements, and making sure that the athlete is eating properly, it does reduce the risk of a bone stress injury occurring. It found supporting evidence that rehabilitative techniques also have an effect on the return to play timeline, using the proper protocols laid out in that one study show to have a quicker return to play timeline than trying other things or doing something that is out of the ordinary. So the clinical bottom line for this, return to play is based off the amount of pain an athlete has with functional movement. So that's what we base our return to play on. Once they can handle the pain and the stress, they will be able to move on. return to play has been shown to be lesser when a lower grade MRI is present. So a less significant injury shows a less significant return to play time. Some evidence shows that following a correct rehabilitation protocol can decrease pain faster in athletes, which does decrease their return to play time. Some evidence shows electrical stimulation can decrease pain, so trying to implement that in your clinical setting. And then some evidence shows that preventative techniques can lead to a less significant injury when one does occur, therefore creating a shorter return to play time. Future research, I want to do more research into what we can do to the rehabilitation protocol to shorten this return to play time. The preventative measures need to be studied, trying different techniques in a larger sample size in order to get proper statistics on how much it affects the return to play time. And then if these two topics can be studied in a controlled setting, fully written protocols, we can concur the total effectiveness of each technique within the setting. There are my references. I'd like to thank my Lord and Savior Jesus Christ. I'd like to thank y'all, the JSU Symposium, for having me. I'd like to thank my professors at Jacksonville State, my classmates, and all of our future and previous graduates who have helped me so much within the MAT program. Are there any questions?
So a previous presenter had mentioned female triad, which you mentioned again here,
Yes.
and one of those was low energy availability.
Mm-hmm.
Can you explain, are we talking about stamina or something else?
So low energy availability has more to do with caloric intake. So you only have as much energy available as you have consumed. So when I was talking about the diet and how that leads to a higher risk when you don't have that energy to use, that's all it is. Not eating enough, not eating properly. So I'm sure you've heard of like carb loading for athletes prior to a game where they eat more carbs in order to have more energy available. So when they don't have that energy available, it leads to that higher risk of injury. Yes?
You said that starting sports or activities later, do you know like what the threshold is for later?
So it was after 12 years old. 12 years old athletes who were participating in these sports, especially sports that involve a lot of running, it found that if they started after 12 years old, they were actually at a lower risk for a bone stress injury. But it's also to say that there is evidence out there that as a kid, it's important to go out and play and be active because bones grow based on stress. So it's kind of like a catch-22 there, where you have to find a right level of not competing year-round, but having good activity levels and having play in order to build that bone up and make it strong without leading to further injury down the line.
Other questions for our speaker? All right, let's thank you again.